I'd like to acknowledge that we are hosting this session on the unceded and ancestral territories of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, and the Métis Charter Community of the Lower Mainland region. And all of you around this province and this country, Turtle Island, are on your territories. And I know that we're all grateful to be sharing this land in this moment. Next slide. So I want to introduce Dr. Clara Bohm. Many of you may know her, but not all. Clara is an associate professor at the University of Manitoba. She's a nephrologist in the Manitoba Renal program. She completed her MD at McMaster and did internal medicine at University of Saskatchewan, and then nephrology training at Dalhousie, and has a Master's of Public Health from Johns Hopkins. She has really an amazing range of clinical and research interests, but mostly focused or wholly focused on improving the quality of life in people on dialysis. She's actually the lead for CanSolve CKD Triple I project, which tries to identify the challenges and develop solutions that improve patient-centered care in hemodialysis units. She leads a number of nationally funded clinical trials that characterize the effect of exercise on symptom burden and functional status in people on dialysis. And she's been an early adopter of the whole notion of patient engagement and has worked tirelessly, and during COVID did some amazing, very extensive grant writing to see if we could get some interesting grants going for studying the hemodialysis population. But I think today she's going to talk to us about virtual care in hemodialysis. What do we need to think about, and why should we care? And we should have some time and lively discussion. So Claire, over to you.
I'm just going to share my screen. And is it on the wrong setting right now? There. Full slide. Good. Okay.
Yeah, perfect. Yeah.
And can you hear me? Yeah. Okay. So thanks for the invite, and I'm happy to be here. Not really here, but I'm excited to talk about this topic. And for the purpose of this topic, I'm going to focus on in-center hemodialysis care. As Adira said, that's where a lot of my clinical research has been. So where I am right now, where I live, work, and play, is in Winnipeg, Manitoba. And for those in the mountains, I'm going to show you something other than prairie and cold. This is my favorite spot in the summer, and it just reminds everybody of all the water and lakes available to us to play in Manitoba. However, unfortunately, this is what it's currently like here and what everybody expects from Winnipeg. We're actually in a blizzard today. So today, I would like to just talk about and define the meaning and scope of virtual care in the hemodialysis context, and a few other definitions related to virtual care, just so that we're all on the same page to begin with. And then we're going to discuss how virtual care might be used or might be appropriate to improve patient-centered care in the hemodialysis setting. I'll talk about some uncertainties and concerns related to the implementation of virtual care in hemodialysis, and then discuss the importance of evaluating virtual care interventions in hemodialysis. Hopefully we'll have time for discussion at the end to kind of improve everybody's understanding and the importance of this. So definitions first. So by now, most people are familiar after the pandemic with virtual care, and it's really defined as any interaction between patients and members of their care circle occurring remotely using any form of communication or information technology. And the aim of virtual care in this context is to facilitate or maximize the quality and effectiveness of patient care, or at least that is what it should be. Types of virtual care are quite diverse and include telephone, which we've been doing for years and years, email, video clinic visits, remote monitoring, both in clinical settings. So for example, remotely monitored ICUs, or home-based, where patients are at home and we're monitoring them in the clinic for blood pressures or other biometric things. And then there are also mobile applications, and there are many of those, and we'll talk about that as well. Last definition, e-health versus m-health. So e-health incorporates healthcare activities or provisions supported by any electronic processes. So that could include this old computer room that existed long ago. And m-health, in contrast, is a little more focused. It's the use of mobile wireless devices to support or provide healthcare activities, and that includes smartphones, tablets, personal digital assistants, and patient monitoring devices. And so such as my Apple Watch that you see there. Just kind of a general overview that in nephrology, we are a little bit behind the rest of the medical world in terms of virtual care. So this is an old slide, but 2017. Kidney disease only made up 1% of the disease-specific apps that were available at that time. I don't think we've grown that much either since then. And it's no different in dialysis, and specifically in hemodialysis. So this was a systematic review done looking at virtual care and specifically telehealth interventions in dialysis, and there were really only 6 hemodialysis interventions that had been published and as an RCT, or a randomized crossover trial, and 2 were for home hemo. The other 4 were for hemodialysis in center, 1 remote clinic care by virtual visit, self-management for adherence, and then mental health intervention. So it's pretty limited what's in the literature specifically for hemodialysis in terms of virtual care right now. So my first question, or my first objective, is really to discuss whether virtual care can improve person-centered care in the hemodialysis unit. And why would we think about it if we're seeing these people 3 times a week often, or at least once a week when they're coming in? So one more definition, because we tossed these 2 words around kind of together, and they actually mean different things. So person-centered care is where we focus on the individual, their family, and their friends, not the disease. It promotes an equal relationship between people who use health services, aka the patient, and people who are responsible for services. And everything that's done through patient-centered care is co-produced and co-designed by both those entities, so that health services and experiences are actually truly a collaboration between health professionals, the people responsible for the services, and the people who use the services. Patient-centered care, on the other hand, is a little more focused on the disease, a little less focused on the holistics of the patient themselves. There is patient engagement and consultation. Patients express views, fill in surveys, attend meetings, but they may or may not be able to influence decisions and make significant changes to health services and experiences. So related to person-centered care and patient-centered care, and I'm going to say person-centered care because that's what we are trying to do. As Adira mentioned, I'm lead of the CanSolve CKD Network III study. This is a multi-center, multi-phase mixed method study in 7 centers across Canada, where our goal is really to blow up hemodialysis, in-center hemodialysis care, and improve it from a patient-centered perspective, specifically in 3 different areas which are listed there: information, individualization, and interaction. And so with many colleagues and collaborators across the country, we've actually started by collecting the top 10 challenges to hemodialysis care from the point of view of these 3 I's. That's why it's called the III. And we did that by through focus groups, a cross-Canada ranking survey that ranked the challenges, and then a priority setting workshop that actually identified the top 10 challenges and also suggested some possible solutions that we can work on in the future. So the top 10 challenges to hemodialysis care, as we found, all relate a lot to information, so timing, frequency, and amount of information, continuity of care in dialysis, improving the way information is communicated between healthcare providers and patients, but also actually just between healthcare providers in the unit and elsewhere. Trying to get at, care outside the dialysis unit, and it's frustrating to have to go for care outside the dialysis unit when you're in dialysis 3 times a week. And then more information and resources for financial support, transportation, housing, and nutrition and diet, flexibility in hemodialysis schedules, information about the pros and cons of dialysis modalities, more information about other health risks associated with dialysis, transplant information, and access to social programs and mental support for people on dialysis. And why am I listing this? Well, because I think that actually for many of those problems, virtual care in hemodialysis is actually a potential solution. So increasing interaction between providers and patients could be through portals for communication or symptom diaries that then patients can bring in. Hemodialysis transportation and hemodialysis scheduling could certainly be done virtually by the patient through an app or through a web portal. Patient navigators could help with transplant and some of the questions about dialysis modalities and other health problems. Health records and test results patients could have access to on portals, peer support, and lifestyle modification, and it goes on and on. I'm not going to go through all of them, but essentially virtual care has the potential to address many of the challenges that patients have identified to person-centered care in dialysis. So is there evidence that virtual care can actually is effective at addressing some of these problems? So I'm going to go through a few studies and RCT and systematic reviews. So the first study was really long ago, and this is kind of to highlight that this has been going on for 10 years in many places. We've been trying to get virtual care up and running, and it's still not ubiquitous, and we'll talk about why in a little bit. So this was home-based monitoring for individuals receiving facility-based hemodialysis who were at high risk for hospitalization based on an algorithm that they used. And they randomized 44 individuals, 19 to home monitoring via remote technology, and 25 just to usual care. And so the home monitoring was this Vittel Turtle 500, which looks like a very old machine now, not a turtle like this. It included a blood pressure monitor, scale, pulse oximeter, glucose monitor, and a video camera and headset so that they could communicate when they needed to with providers. Basically, education regarding its use and actually installation in the patient's home was provided, and then patients did measurements and submitted them on non-hemodialysis days. And this really showed, this study showed a very significant decrease in the number of hospitalizations in terms of hospitalization frequency, number of days in hospital as well here. This is usual care, this is remote monitoring, and also the number of emergency room visits. Interestingly, there was no improvement in quality of life. And actually, we've seen that with some of our work with virtual care here in the CKD clinic, and I'll discuss that a bit further under issues. This study was at 21 months. They did a follow-up study at 3 years where they found no significant difference in emergency room visits, but the hospitalization frequency in days was still significantly lower in remote monitoring. Another systematic review, excuse me, of telehealth in dialysis, which included the study I just talked about, done by Lunny et al. From Calgary in 2018, only identified 5 articles or 5 studies that looked at any remote monitoring or telehealth in dialysis. And of those, 1 was in Canada, 2 in the US, and the other ones elsewhere. And you can see that the interventions were quite heterogeneous. Some were remote monitoring, some were video conference for satellite clinics and phone calls. And there were benefits, as mentioned, to hospitalization and ER visits in some, but not all studies, and also benefits to quality of life and mental health seen there. But again, it's hard to compare and hard to meta-analyze, and there are, and again, very few studies. In addition, just to bring home the point that if we're trying to do person-centered care, yes, they address mental health and quality of life, but some of the studies didn't look at patient-important outcomes that we would be trying to look for now as part of III. Another systematic review specifically of mobile health in dialysis found 22 studies. The majority were from the US, but they were English only and only between 2008 and 2018. And you can see that they again were, the apps were a number of different goals, so nutrition and diet self-monitoring, biometric monitoring like blood pressure and weight, a web-based portal to communicate with providers, self-monitoring of dialysis with specific information during dialysis, and then self-monitoring of lifestyle or behavioral change. In this study, it actually doesn't show a lot of hard data, but the platforms were also very heterogeneous, and they had 10 studies out of the 22 were specifically in hemodialysis patients. And they, again, no numbers, but they do state, and they didn't separate out hemodialysis in the analysis, but they do state that there was benefits to dialysis specific measures, improved behavior in terms of adherence to treatment and lifestyle changes, decreased health resource use, and also there was general satisfaction and acceptance of mHealth use in dialysis. However, again, just bringing home the point that none of those outcomes that they've listed are actually the ones that have been identified as a priority for people in in-center hemodialysis. And lastly, just to bring this home again, there is one study from 2019 looking at evaluating apps for chronic kidney disease by both nephrologists and patients. And in that study in CJSON, only 6 apps were identified for hemodialysis, and none were scored highly by patients or nephrologists in their evaluation criteria. So we've still got a long ways to go for this to be kind of ubiquitous standard of care and acceptable to patients. One of the top 10 challenges that we found in III was improving patient and provider communications. And we know that hemodialysis rounds can actually be a barrier to patient-physician interaction because interactions are time pressured. Patients have told us that they minimize or forget to mention some issues to the physician when they come around, and a lack of privacy. And so as part of a sub-study for the III project, led by Stephanie Thompson at the University of Alberta, we aimed to develop and test the usability of a web app to support patients prioritizing their dialysis concerns outside of the clinical encounter at home. And we would hope that it would improve the delivery of individualized health information during rounds. So this was a mixed methods, multi-site parallel arm RCT. It included patients receiving in-center hemodialysis who were randomized either to a web app where they could input their concerns for the nephrologist in the week prior to rounds, or an active control, which is a paper form which they would give to the nephrologist at the beginning of rounds, and they would log their concerns weekly over 8 weeks. And the attending nephrologists were also enrolled so they could log into the app and see what the patient's issues were prior to rounding each week. Topics that were addressed, there were specific topics that patients could input issues with, and those were hemodialysis treatment, hemodialysis related symptoms, modality questions, and medication questions. The primary outcome of this was usability, and so tool engagement and frequency of use. What we found is that in terms of usability, interestingly, everyone engaged with the paper at least once over the paper version, at least once over the 8-week period, and about 70% of the users engaged with the tool over the 8 weeks period, so the web app or Voice HD. And then similarly, more people entered paper concerns than concerns into the web app. However, most patients felt that the concerns were satisfactorily addressed, and were happy with the app in terms of our qualitative analysis as well. As we can see here, there's another patient satisfaction, and really there were similarities between the web app and the paper tool, and the only thing that was different was the time required to use the tool was seemed to be longer with the web app than the paper tool. And so the only other thing I will say about the Voice HD is that it did seem to be well accepted by patients, and this was the first iteration of this web app. So there were certainly modifications we could do afterwards, but the nephrologists actually did not think that it added anything to care. And despite the fact that patients liked it and really wanted to use it, nephrologists felt like it just added too much time and was not efficient. And so this just brings home the fact that it's really important to, when you're designing these virtual care interventions, to really think about who your target audiences are and actually engage with both, if it's physicians and patients, to try to make it work for both. And that brings home this, is that our current virtual care patient options, patient-centered, and patient-centered would mean that they're designed by patients for patients, or there's a collaboration between individuals on hemodialysis and the healthcare providers in designing them. And in all the systematic reviews and studies I reviewed, there's really not much information on whether patients were involved, and often patients were not involved. It was providers or the healthcare system designing the app. There is one systematic review that states actually that only less than 1% of the studies that they looked at had any mention that patients were actually involved in the design of the app. So that is another thing that we need to work on. So speaking of that, what do people receiving hemodialysis think about virtual care and how it would be useful, and whether it would be useful? So if we look at the general population, and this is from the CSN at the ASN last year, Claudia Regato presented this, there are a lot of people who think that it would be more convenient, timely, less costly. So in the general population, the perception is that definitely virtual care is useful. Wael Hussein and colleagues actually just published recently a great summary of whether patients are ready for virtual care or not. So, and it was really mobile health technologies they looked at. And in this study, they took patients from 21 centers that satellite healthcare, dialysis centers that satellite healthcare runs in the States. And they asked them about their frequency of use and whether they had whether they had mobile devices. And as you can see, I'm going to focus on the in-center here. In-center hemodialysis, people use the internet frequently, over 70% usually, and over 80% of individuals had a smartphone. Only 50% had a tablet, and technological readiness was about 67% in center hemodialysis. So certainly not everyone is ready, but the majority of people in the US appear to be ready and willing to do virtual care. And not only are they ready and willing, but they're excited about it. You know, when they're asked about what they would use mobile health apps for, there was a myriad of things, including communication, appointment reminders, scheduling appointments, information about their dialysis. And so it really does look like, in the US at least, individuals on dialysis seem to be ready and willing to use it. However, they also looked at mobile health proficiency, which was a test that they had put together and piloted. It's really a survey questionnaire. And what they found is that at least 30%, 35% almost of people on in-center hemodialysis have no or basic level of proficiency for mobile health. So they won't be able to really use an app. And then 66% were intermediate or advanced, where they would be able to. And so this is really an important question. Is yes, people want to use it, but it maybe gets to the Voice HD issue, which was, yeah, they were interested, but it took longer and probably related to the level of proficiency. And so back to Voice HD, this is a bit different in Canada. What we found in Canada in our study was that baseline use of digital devices in our population was low. It was 20%. And of the 258 individuals who were able to participate, are eligible to participate, 181, so 70% declined participation. So, you know, in Voice HD study, it was a very select population of people who actually participated in the study. So I'm not entirely sure that we're ready in Canada to embrace virtual care for everybody. One more point related to this, as part of the III solutions, we're developing we're trialing a study called Hubs of Care, which is really aiming to bring multidisciplinary team members and healthcare providers who traditionally see patients in separate clinics, such as cardiologists, ophthalmologists, into the unit, with the goal of improving communication with patients and healthcare providers, decreasing the time and costs for patients with traveling to appointments, and improving the overall experience in hemodialysis. And we think it will improve clinical care too, and clinical outcomes. So the initial thing that we're doing is actually just doing an environmental scan of us in 7 provinces, in units in 7 provinces, with looking for what specialists, what providers would be preferred to be visiting in the unit, and what would their preferred visit mode be. And we just actually completed, most of our sites have just completed this survey, and we analyzed it, did a preliminary analysis on it. And interestingly, we actually asked healthcare providers and patients, and not everyone, not even healthcare providers, wanted virtual visits. So specifically here for patients, patients said either only 24% of patients said either in person or by video, and 76% of patients actually wanted only in-person visits. Providers was about 50-50, but it really, again, brings home that maybe not everyone is ready for virtual care in Canadian hemodialysis units. So, which brings me to uncertainties and concerns with implementing virtual care. So what are some uncertainties, or should we just implement it with no worries? So pros and cons. So the pros really, and many of you may have thought about this as well, but family and caregivers can participate if it's a video call or even a phone call, even if they're at different sites across the country. And as someone with a parent who is very sick, far away from me across Canada, this is actually very useful and very helpful for the patient, but also for their family and the provider. It's more convenient for patients generally, decreased travel and time savings, but only if you're proficient in the use of the virtual care or you have someone who can help you if you're not. And it would, with the remote monitoring, it will also provide information that might not be available in the hemodialysis unit about how our patients are actually living and if they're living well, which is very important for patient-centered care and person-centered care. Cons are, and what we found in Manitoba, is that, not all places in Canada have access to reliable internet. And I'm quite sure that in BC it's similar to Manitoba, but we have very, very remote areas where I can't even call somebody on a cell phone. The cost of technology for patients is prohibitive for many of our patients. In order to make virtual care work and any type of virtual care, you need a champion in the clinical area that will take it on and be the troubleshooter, both for the clinical area, but also for the patients. We've discussed in previous venues that it's not really appropriate for all care interactions, that there are some interactions that must be done in person. And we actually aren't sure what those interactions are yet. We don't really have a template for when to call somebody in or tell them they need to be seen in person. And then this other point here may lead to more worry. So in one of the systematic reviews that I presented, quality of life actually decreased in the intervention group, in the telehealth group. And some of the preliminary work done with our virtual care and virtual monitoring in CKD clinic that Claudia Rigato is doing here in Winnipeg has shown that some patients really did get more anxious and more worried about their health with the biometric monitoring because they saw themselves declining over time, and it made them actually quite anxious and worried. So again, that's something that needs to be addressed or at least acknowledged. And lastly, this is again from Wael Hussein's paper about mobile health apps and readiness. Are we introducing bias and excluding people? So this just showed who has higher proficiency and who had lower proficiency overall. And so younger patients had much higher proficiency in mobile health technology. People who were less educated had lower proficiency, as did people who were non-white. And if people were employed or going to school, they actually had higher proficiency too. So again, this could actually, if you employed a virtual care intervention throughout the unit, you could actually be excluding people and preventing people from getting care that may not be able to use this technology. Other issues, our infrastructure is lagging behind in Manitoba and in other places in Canada too, and particularly infrastructure that not within the healthcare system, but the internet and cell phone infrastructure. I know that cell phone companies and wireless companies are now trying to work on this with governments. Interoperability of systems. So if you have one virtual care system, can it communicate with all aspects of the health of electronic health or not? And that's a real problem as all these apps and virtual care interventions are being developed. They won't all be able to communicate with our healthcare system. Currently, after the pandemic, people are really stretched in terms of being able to do anything more in healthcare. And so it's hard to find a champion to help pull together clinical virtual care interventions and support patients through it. And again, just to underscore the technical difficulties that I have in my clinic every week when I try to do video calls with patients. Megan Lunny did a trial of Zoom clinic visits with nephrologists and individuals on hemodialysis in Calgary, and it was in-center patients, but they were doing Zoom clinic visits for follow-up and assessments. And they were very successful and accepted well by patients and nephrologists, but they had somebody who ensured that patients could get help with setup and any technical difficulties. And they acknowledged that there's no way that it would have worked unless there was a dedicated person to do this. So these are all the things that need to be considered when we are implementing virtual care interventions. A few more things. So one size does not fit all. So you can't just take a pair of pants or a virtual care intervention from somewhere else and send it and expect that you're going to be able to implement it in your center. The interventions are very specific to the target audience or the target population that you're trying to make it work in, and also the goal. What is the goal of the virtual care intervention in terms of outcomes? And it also factors affecting failure or success of the program of the intervention are actually very specific to each renal program site, maybe not even just the renal program. And so what's very important is that before implementing a virtual care intervention, doing the homework and doing the preliminary consultation work with all stakeholders is really, really important. And again, that also includes considering barriers and facilitators to the intervention. So that individual characteristics of staff and patients, the resources and the location and the infrastructure available to support the virtual care. And Lunny et al. In that telehealth Zoom intervention study found that factors that influence the virtual visit success were IT infrastructure, administration, and then the process itself and working through the process with each site. And last but not least, I think this is really important. So one of the patient representatives on the virtual task care force for this Canadian Medical Association said, as we think about the possibilities of virtual care, we need to collaborate with persons who have lived experience to ensure virtual care technologies are supportive of the patient experience as well as outcomes. And I think this is exceedingly important. And I think based on the reviews that I presented, the studies in virtual care have not actually considered, have not included persons with lived experience in terms of development or evaluation for the most part, and they also haven't included patient-important outcomes either. And just a last little bit about evaluation of virtual care interventions. So why should we evaluate? Well, frankly, just to make things better. If we don't evaluate, we could be using an intervention that is not useful and costs us a lot of money and doesn't make life better, might make it worse. for patients. There's limited evidence for virtual care in hemodialysis, and we need to start providing that evidence so we can move forward with this. Again, each intervention is specific to its location, target population, and goal outcomes. So the fact that it works in one center or one dialysis unit doesn't mean that it'll work in another one, and each needs to be evaluated. Again, we need to include individuals receiving hemodialysis in each step of implementing virtual care, and especially with the evaluation to make sure that it works for them. And then specific things to consider when evaluating an intervention is its usability, satisfaction, both for patients and for the provider, and then efficacy for the selected outcome. But again, you want to select what the outcome is and find the right measure for that particular outcome. And also, as my cat looks going, come on, man, it's just the right thing to do. We need to evaluate so that we collect the data. So in conclusion, there are actually, I think, many opportunities and possibilities for virtual care to improve person-centered care and patient-important outcomes in hemodialysis. And I'm actually excited about these possibilities and that we can start working towards them. We have some evidence that virtual care interventions are beneficial, but maybe not to the outcomes that patients think are the most important. It's very important to remember that one size does not fit all. You have to consider the individualization of each particular setting, unit, the target population, the resources available, and just evaluation is the key to moving forward with virtual care. It needs to be rigorous and actually relevant to what the intervention is and the outcome is. And that's the end. So thank you for letting me talk about this. And I just want to thank all the III collaborators and team members across Canada, the CanSolve CKD network, and collaborators and colleagues at the Chronic Disease Innovation Center for help with all my work.
Great. Thank you, Clara. Whoops, yeah, here, let's go back to, can you hear me? Yes?
Yeah, you're in and out again.
Yeah, I know. Yeah, I don't know what's happened. Anyways, so thank you for this and for that overview. And I think, one of the things that struck me, which I hadn't sort of heard articulated before, is like, what's the purpose of virtual care in the hemodialysis unit? For whom, for what purpose? And I think, and then it's different in the kidney care clinics and for home-based therapies and remote monitoring and the kind of confusion between virtual care versus apps and medical devices that help you monitor people and different things. So I think that is an important clarification. There is a question in the chat. Yeah, it's a very good point by one of our senior fellows. People who don't speak the local language have less opportunity to voice their concerns in the dialysis unit. What has been their experience with virtual care, and have they been included in the studies? And I think, certainly in our Canadian culture, this is a really important thing.
Yeah, and they, in general, have not been included in the studies. The readiness for mobile technology, I'm actually not sure. I'd have to go back and look if people who do not speak the language were included, but in general they're not. Some of our III work has used translations for the surveys and things, but the virtual care results I presented were not, other than in French, and were not translated.
Yeah, I think that's an important point, right? Like, I know certainly in Vancouver, at least 40% of the dialysis population are not English speaking. But I was intrigued also by your comments, like there's so little privacy in a dialysis unit, and there are different ways that people have dealt with this. I know that in some centers they have a separate clinic where people come to have that private conversation. But what you're suggesting is that, you know, perhaps that could be like there's a way that virtual care might actually help you with some of that. Now, Kathy, there's various questions here. Virtual care to more remote dialysis units. I think one of your comments there was also in terms of it, you have to have internet access, but.
Yeah, so I think in Manitoba, one of the very useful things we have is telehealth through the actual e-health, and that works, but the patients in remote areas have to go to the nursing station to do telehealth. That's advantageous to us as providers because there's a nurse there and they can answer some of our questions, do a bit of an exam. Maybe not so convenient for patients. I have tried to do some telehealth, some video, again, run by our digital health, but video consults in more remote areas that do have internet, and they have not worked. It's just the bandwidth is not big enough. It's really not, it's very hard. And even sometimes cell phone service is a problem. So you can't even do a telephone call.
Yeah, and again, maybe, do you want to maybe, while I'm just waiting for other questions, hypothesize, like, you know, the cardiologists are big on, you know, apps for, you know, exercise and eating and heart rate monitoring, et cetera. Are there things that we could do in our population?
Yeah, so in hemodialysis, I think, I didn't have time to wax poetic about everything I think we should do, but I will let you know that the III study is working on one more immediate and a second more remote virtual care thing, and it's apps. So we're developing an education app specifically for hemodialysis patients that is being developed by our patient partners on the team. So it won't be the physicians and the researchers putting the information in, it will be the patient partners. And there's a personal navigator embedded into it, not a person, it's like a virtual navigator, but you can really get the right amount of information at the right time for what you want, rather than, you know, starting dialysis and getting dropped all this paper information that you will never remember and things. So, and that app, then the idea is that we will then add different layers to the app. So second part of CanSolve for III is looking at mental health treatment, and so we're hopeful that whatever comes out of that will then there will be a virtual component of it that could go into the app. Other things that I really think are so amenable to virtual care and apps and mobile technology is scheduling of dialysis treatments. Like, why can't dialysis treatments be like an airplane seat? And why can't patients, I mean, there have to be some rules, like you do actually have to show up once in a while, but otherwise, you know, why can't they just be, and why can't that be linked to transportation so that automatically if somebody changes their shift, it goes to the Uber for dialysis, yeah. And it changes and nobody has to know, and it's more efficient. You know, and again, even, you know, transplant status and what you have to do for transplant. And I don't know if BC has a portal or something that patients can go to, but in Manitoba, there's nothing. It's like us calling transplant and finding out what needs to get done and things. So, yeah.
Yeah.
Those are some things.
But that's been worked on. I think people are working on it. Like at least there's the information.
And I think that's, I mean, I think the other thing that is natural in this environment is that everybody is in their own little silo developing their own little things. And it's just unfortunate that we can't get everyone together to develop something because, you know, Adira, you know, you might be developing a lifestyle intervention app and I might be developing the travel app, and then they won't talk together. They won't end up talking together, and they won't be that useful. And so, yeah, I think it's too bad. It'd be nice if we could have an app community, you know.
Yeah, well, and also just even I'm thinking like, you know, Google knows how to translate everything. So like, why do we spend inordinate amounts of energy translating stuff when, you know, we should be able to build something in Canada that has, you know, the top, you know, 8 languages that, you know what, and it just automatically does it. And you're right, like if we could get the communities together to figure out what it is that would be most useful.
Yeah.
But to your point, it has to be evaluated, right? Like what is useful to people in Manitoba may or may not be as useful to people living, you know, on Vancouver Island. Like,
Yeah. Do I press this?
yeah, I could. I find
Live?
patients who have, so
I
yeah,
don't
so
know.
no, oh, I'll read it. So the patients who have low education have low medical literacy and are most disadvantaged. Can you see virtual health apps helping this population?
That is an excellent question, Beverly. And yeah, I think that was kind of the point about, you know, all of this virtual care and specifically the apps are, there's a component of the population in dialysis that may not be able to use them, as we found in our Voice HD. So 2 things. I mean, you know, if it's medical literacy, then that can be addressed by actually targeting low medical literacy, but I think there's also technological literacy, and that's more of a problem. And I do not think that currently, maybe in 20 or 30 years, when everyone who is on dialysis was using an app when they were little, but currently I don't think we will be able to just have you know, interventions that are only virtual or only mobile apps, because there are people who just can't do that. You know, one option, can't afford it, that's different. We could provide apps, but really just not technologically able to. And I have to tell you that in my, I mean, this is not hemodialysis, but in my clinic, I really, like, all we were doing for a long time was telephone because of COVID. And I did not like telephone. It makes me very anxious. And I thought, you know, video would be better. And so I really tried to get, and we have a good app. It's actually a platform that the patient just has to click a link. Like, they don't have to do anything else. They just have to click a link. And I only had perhaps 1 out of my 12 to 16 patients in clinic ever agreeing to do it. And when they agreed, it almost always worked. But, you know, it is really hard to get some people to do this.
Yeah, I mean, you're raising a good point. Like, what we're designing in the moment may not be what is needed in 5 to 10 years' time, because the population coming onto dialysis will be different.
Yeah.
Will be very literate in a different kind of way. So,
yeah,
you know, solving today's problems without an eye to what the future like technology literacy will be.
And I think that's, the other inherent problem with this is that, you know, you design an app and it takes you a year or 2 to design it, and by then it's old and it's not, you know, it's really difficult to keep up.
Yeah. Well, I don't see any new questions.
Can't hear you again, Adira.
Sorry. It's a very new problem with me. Okay, so I can't see any new questions, and it is almost the bottom of the hour, depending on which province you're in. But I want to thank you for helping us to conceptualize virtual care, and also the work that you're doing. And I think that there are many people in this province who are quite interested in optimizing virtual care, but also understanding the difference between, you know, visits versus apps versus, you know, things that help you educate people, and there's a lot of work to do. So thank you for spearheading it, and we will come back to you and see where you're at in a couple of years, if sooner. Thanks again for making the time. I know you're in the middle of a busy week, so and thanks to everybody for participating.
Thanks, everyone. Thanks for listening. Bye.